medicine. He published many books, the last one being Decision-Making in Neurovascular Disease, which is extremely useful for fellows, specifically, I believe. He's the president-elect of the Congress of the CNS for the term 2022 and 23. He's the past chair of the CNS Foundation, is also one of the 12 members of the boards of the American Board of Neurosurgery. So Dr. Levy, thank you so much for joining us. And it's a pleasure to have you. You can share your screen.
Thank you, Matthias, and thank you, Doctors Monteith and McDougall and the rest of the team for inviting me. Always an honor and a privilege to be with friends again and discuss and share some thoughts. And I have my esteemed fellow Andre, who's a tech whiz, who's going to help me get this shared. Can everyone see this screen?
Yes, that was great.
Great. So I know that at your hospital, you do a lot of radial, so we're not going to go into kind of the whole concept of how to do radial diagnostics. And it's really become sort of a hot topic now, almost like it's new, and there's a buzz about radial access and radial first, and that's a hashtag on Twitter, and I should have probably, in retrospect, put a slide of that hashtag radial first. But I'm sort of trying to go the other way, and it's not about radial first or radial versus femoral. Like, it's not about clip versus coil. It's always about patient first, and what makes the most sense for that patient that's on the table in front of you when you're about to get access or think of a way to treat that aneurysm or AVM or other cerebrovascular entity. So what we're going to talk about today is when the patient and not radial comes first, and choosing the access site based on thrombectomy. So let's see if we can move this slide forward. Okay. Lots of disclosures, but for today, nothing specific for this talk. And I always start with this slide, famous quote by Carl Sagan: you have to know the past to understand the present. And why is that germane for today? So when you talk about transradial, where did we learn this transradial premise from? Like in many things in neurointervention, a lot has come from the cardiologists. And I know Dr. McDougall and my mentor, Dr. Hopkins, have often talked about borrowing concepts from our cardiology colleagues. And they were really the first to do radial approach, and it makes sense given that anatomy, and I'll show some slides later on that anatomy. And what we learned from them is the reason they've migrated to that is patients said they had less postoperative pain, they can mobilize quickly, and obviously you avoid the risk of retroperitoneal hematomas, which can cause severe morbidity and death. And they had a lot of trials. A Tempora study is something that was published in 2003, 2 decades ago, comparing transradial to transfemoral approaches for stenting in the coronary circulation for myocardial infarction. So is transradial that hot topic? How new is it? When did we start doing it? And you know, what's new or what's old is now new again. So is neurointervention late to the party? And the answer is no, right? So I, as several, and my colleagues here, Bernard Bendock and Adnan Qureshi, Nick Hopkins and Lee, we were doing transradial stenting for carotids. And you can see this paper, 2003, almost 20 years ago, we were using the transradial approach. So it's been feasible for 2 decades. And the indication at that time, which is not so different now, it wasn't sexy, it wasn't hot, it was sort of a necessity when patients had contraindication of femoral access. So they had severe femoral artery disease, or they were amputees, or it was just truly not feasible to get through from a femoral access. So we went to brachial or radial access in those patients. And Nick Hopkins, who I give all the credit to in this, always has a long vision, has tremendous foresight. He started to say, hey, why can't we do angiography through a transradial approach? So when I was a fellow here from 2001 to 2003, we published this in 2002, literally 20 years ago, 2 decades ago, a series of 100 radial angiograms, consecutive angiograms. And again, we showed that there was a feasibility. Now, our tools weren't as elegant. The catheters were stiffer. We didn't have wrist, 6 French wrist, 7 French wrist. We didn't have the tools that we have today and the suppleness, but we showed that it was feasible and it's a fine alternative. And then it sort of died down and it was difficult. It took more time. It was annoying. So it was always a backup option until the technology caught up. So catheterizing from the cardiac vascular from a transradial approach takes a direct path into the brachiocephalic trunk, as you can see here. So if we're going up the radial and then we want to get into the heart, that's just a dump, right? You can just come up, go into the subclavian, and then you just dump right into the coronary circulation. It's very easy. But for, as you know, for neurointervention or neuroangiography, we have to reconstitute the heart. And if they have a sort of lax valve, you get into the heart. If you can't necessarily go up the vert and reconstitute there are many different techniques. But depending on the arch anatomy, it can be quite complex. And in addition, if you have to do an intervention, place a stent, thrombectomy, you don't have the support. So depending on the arch type, it's very easy to herniate the entire system into the aorta. So aortic arch variations, carotid tortuosities, if you have to get support to navigate these loops with devices, it just makes it made it challenging. But with the development of new technologies, it becomes less so. So older catheters were clearly stiffer, the Cordis SIM2s, they're difficult to navigate. But now technology has given us catheters that are supple and specifically designed for neurointervention through a transradial approach. So as they became more flexible and more versatile, it sort of became new again. It became of interest. It was less of a backup because it was less of a challenge and didn't require effort. So in general, when we care for patients, part of our treatment algorithm is path of least resistance. We want to do what's best and safest, but at the same time, as surgeons, we also don't want to struggle because struggle typically leads to worse outcomes. So as we have softer devices, for example, Sophia, wrist, other catheters, we were able to do support catheters, power towers are what we call them, and now specifically developed for neurointervention. So Matthias and the other fellows there now have a new skill set to master. And there is a learning curve for transradial access. And we've published several papers on the concept of this skill set and the learning curve specifically for transradial access, meaning how to cannulate the radial or potentially the brachial artery if the radial is missing or too small, potentially how to cannulate the ulnar in some very rare situations, how to manage that radial artery loop. So there are not significant, but a reasonable amount of patients that when you inject contrast through your sheath, you see that radial artery loop. So how do you navigate it? How do you either straighten it, avoid it, deal with it? And Jason was a senior author on that case series. And then sort of using endovascular procedures, now not just for angiography, but for thrombectomy, for stenting, for AVM embolization, looking at procedures now done through a transradial, or in this case, wrist catheter guide. So the information is out there, transradial versus transfemoral approach for neuroendovascular procedures. And Andre is now sitting to my left to help put this slide together, was a senior author on a survey of patient preferences. So first of all, we're doing this because we think patients want this, right? We think they think it's better or that's their preference, but do we know that? And we really didn't know that till we basically surveyed all our patients that had radial and femoral approaches. And as you would predict, 70, actually, I thought it'd be higher. Personally, I thought it'd be 90 or 95% preferred radial, but it wasn't really the case. Barely more than 2/3. So 2/3 preferred the radial approach, and 10% had no preference, and 20% preferred the femoral approach. And this is a survey of patients who went through both a radial and a femoral approach, either for follow-up angiography or for intervention. So interestingly, the people who had preference, pain was the major reason of the preference. So for people who preferred a radial approach, they said they prefer radial because they had more pain in the femoral area. Potentially they had a lot of scar tissue, or they had multiple accesses in the femoral, and it gets more painful every time due to scar tissue. But interestingly, patients who prefer the femoral approach also said it's due to pain, because many patients are right-handed. They said they couldn't use their right hand, or they were limited for a couple of days due to pain in the wrist. And then you can see bruising, other issues, recovery time, mobility, which you would predict. So I was actually surprised, and most of us were surprised, that pain was a predominant predictor for preference in both groups. And as predicted, mobility, but not as predicted, actually, also surprisingly, was mobility. So obviously with femoral, you have to keep the patients flat. We use closure devices on most of our femoral access, but patients were bothered by their wrist and arm mobility. They couldn't use the arm, and for that reason preferred the femoral approach. So some surprising data there. But as predicted, most patients did prefer the transradial approach at 70% versus 30% in the group of femoral or no preference. And now that we understand that these are pain and mobility issues, potentially if we do a better job at the pain management, more lidocaine, maybe less sticks, the preference, maybe now that preference goes away. And again, the mobility issues, if they have less bruising, closure devices, mobility becomes less of an issue. This is an important study, actually. So transradial versus transfemoral approach for cerebral angiography and the frequency of emboli. And we were surprised to learn that the frequency of emboli was almost triple in the radial approach, so 18% DWI, not all of them symptomatic, but versus 5% in the femoral. So again, that's not a small number, 18% versus 5%, really not a small number. And the question now, it begs the question, why? We postulate that when you're coming through a transradial approach, and unless you're just doing the right vertebral or the left vertebral via left approach, you have to reconstitute in the arch. And if you're reconstituting in the arch, sometimes more aggressively than you would in a transfemoral approach, you may be flicking emboli or disturbing calcium or a shaggy arch. So unless you're using a Simmons 2 catheter in a femoral approach, if you're using anything else like a Bernstein, Angle Glide, Headhunter, there's no reconstitution. You're just clicking across, or a VTEC, for example. But you have to reconstitute almost always if you're going to catheterize the carotid vessels, and you're typically either reconstituting off a valve or potentially up the vert, or maybe up a carotid. But most often you're reconstituting in the arch. There's more manipulation. There's more involvement of the valves. And maybe that is why you have triple the emboli. So something to think about, especially in patients, if you have a CTA up front and they show a highly diseased arch or a bad heart, you may want to pivot from a radial approach to a femoral approach, especially if you're cathing the carotid vessels. So in addition to the DWI changes, most of the complaints, some were symptomatic with fine motor impairment, dizziness, visual field issues. So as we sort of now understand that transradial angiography is a wonderful alternative for the right patient, albeit it has some risks. So you want to evaluate the aortic arch. It's not radial all the time. Why not transradial for all neurointerventions? So we always need to be careful about dogma and these hashtags, radial first. So zealots and dogma personally have no place in neurosurgery or medicine in general. So we need to consider all the variables: radial, brachial, subclavian, these anatomic variants. Arch anatomy is critical. Is this a type 3 arch, a type 1 arch? And what is our purpose? Where are we heading? Are we moving? Are we doing something in the basilar artery with a wonderful vertebral takeoff that just, makes sense to come up the radial artery into the subclavian? Or does the vertebral artery come off in a more challenging position, sort of a right angle or a loop, where it makes sense to access a direct shot from the femoral? Are we doing a left ICA intervention. Now we have to go all the way across an arch, and in a type 3 arch, we have no support. And are we pushing some heavy metal, stent reverse, web device, whatever it may be? If we're crossing all the way to the other side, type 3 arch, it may not make sense to use a transradial approach. So arch anatomy is important. Is it calcified, shaggy, carotid tortuosity? What is your target vessel? So this is sort of the mental checklist that we will run through. Anatomic variables of the vessels, the arch anatomy. If we're going to the carotid, what is the tortuosity? So the more tortuous it is, the more support you need. And it's very challenging to find significant support from a radial approach because of arch herniation versus a femoral approach, typically. And then what is your target vessel? So the optimal setup for the treatment being performed to serve the patient has to have these things always considered. So recently, the group here published Radial First or Patient First, a case series and meta-analysis of transradial versus transfemoral access for stroke, which is what we're talking about today. We're not talking about angiography, we're talking about stroke intervention, which is a unique entity for many reasons. It's a little bit of a black box, right? So when we're doing a coiling or a flow diversion or a saccular device or an AVM embolization electively, in general, you have information. You've probably done an angiogram, you've had time to, or some type of vascular study, you've had time to digest, you've had time to understand those 4 criteria: vascular anatomy, arch anatomy, target vessels. In general, in a stroke, this is emergent. You probably have some type of CTA or MRA, depending on your system. So you sort of know what your target is, and also you've examined the patient, you know where the target is. But you haven't really had a chance to digest all the information, and we're moving quickly. So it's still a little bit of a black box. So when we looked at the radial versus transfemoral access in acute stroke, what did we find? Well, as predicted in the femoral access, we can go 9 French sheath, 8 French sheath, 6 French sheath. I'm a balloon guide all the time when possible. So again, no dogma, but my first choice is balloon guide, and not just for stroke, for all intervention. Why? Because now they're supple, they're navigable, they don't hinder me. It's not like the old devices when we're using kind of the Mercy clot retriever and that balloon guide 10 years ago or 15 years ago. It's sort of the airbag in your car, right? You never think about your airbag till you need your airbag and you have an accident. So I don't think, so you have an on-table intraoperative rupture of an aneurysm. It happens to everybody. It's sure nice to inflate a balloon guide in that carotid artery if it's a PCOM and yes, you have collateral circulation, of course. But if I could shut off the main pipe like I would do in surgery, temporary clip something, put up a balloon, we can stay calm. If I'm doing an AVM and I need to modulate the flow, I can inflate the balloon halfway, all the way, 3/4. If it's a high flow fistula, and modulate the flow. So, and then in a stroke, obviously, minimize downstream emboli, have more success trying to retrieve the clot so I'm not pulling against the grain or the flow. So really in everything we do from an intervention standpoint, if access is not prohibitive, meaning if the vessels aren't small, not a vertebral, for example, I would try to use a balloon guide for those reasons. And that's another whole talk. So in the femoral axis, we have 9 French, 8 French sheaths. And you can see in the radial, we cannot use a 9 French and not use an 8 French in general in this study. And 6 French sheaths were used 100% of the time for radial stroke, very infrequently, as you can see here, in the femoral approach. Successful recanalization, as is in most centers, about 90%, but 80% here, and this was statistically significant in a femoral, in a radial approach. Less number of passes, and then statistically significant 3-month mortality was half in the femoral approach compared to the radial approach, and better and more favorable outcomes in the femoral approach and the radial approach. Why? we believe larger devices. So when you put in an 8 French or a balloon guide, we know, and we'll show you some slides. So we were able to use larger access devices, achieve higher rates of TICI2 or greater, lower number of passes, which means that you basically recanalized faster, and that leads to lower mortality, lower morbidity, higher outcomes. Interestingly, but not surprisingly, in the posterior circulation, it was the same. Why? Because in the posterior circulation, we're not using 8 French and 9 French and balloon guides in the vertebral artery. We're using the same access. So even if we go femorally or radially, we're still using a 6 French size guides or up the vertebral artery, because that's what that vessel will tolerate. So now we sort of have equipoise. Same size access devices, whether you go radial or femorally, and amazingly, the mortality and the outcomes were identical in the posterior circulation. So again, this shows us here larger sheaths in the femoral artery, and that allows for the use of balloon guides, which were used almost 100% of the time when we went transfemorally for anterior circulation. Posterior circulation, similar outcomes, no balloon guides, 6 French access, 6 French guides. And this is just another way of demonstrating that. So feasibility and safety. Is it feasible to do stroke through a transradial approach? Yes. Is it safe? Yes. Does it mean the same efficacy? We showed you no. We have double the morbidity, double the mortality in the radial when it's anterior circulation. Identical, so it is feasible, safe, and effective in the posterior circulation, but clearly was inferior in this study in the anterior circulation. But the evidence was out there before. There wasn't a head-to-head comparison, but we knew there was reduction in distal emboli with using balloon guides, first published 10 years ago. And then continued, balloon guide catheter improves revascularization, comparison of balloon guides to non-balloon guides in 2016, impact of the balloon guide catheter and technical outcomes by Brzezinski and Fiorella and Dave Kalmus. So many papers demonstrating the superiority of balloon guides in the setting of stroke. So we knew that. And now we also demonstrated here when you're comparing a femoral approach using a balloon guide to a radial approach when it doesn't use a balloon guide. So kind of what is our setup? And I think that I'll just show this. What is our setup for anterior circulation? It is a little bit dependent on the attending, but for me, I try to make it sort of like airplane traffic control. I don't want anybody thinking about the setup every time changing it. I want it to be protocol and automatic, so it's quick, and we can then sort of focus on the lesion at hand versus how are we modifying the access all the time. And I think that's important too. So they know if I'm on call and it's an anterior circulation stroke, 8 femoral sheath, balloon guide catheter, Walrus in this case, but Microvention makes a nice one too, Bobby, but every company has one. VTech catheter, 038 wire, microcatheter, synchro, and then here we go. That's kind of the setup, and let's see what we see. Do we need to use a stent retriever or just an aspiration device? So here's an example. So obviously we're not using jet catheters anymore. If we are using penumbra catheters, we're using the red line. This was probably a year and a half ago. So CTA, CT perfusion, the cornerstone of our stroke program. No patient gets on the table without this. Why? We want to make sure there's salvageable penumbra, right? So if there's, actually, I'll just go back to this, not that it's germane for this talk, but as you can see here, there's increased time to peak. Nothing is very cored out. So there is preserved volume, albeit decreased flow, but here you can see preserved volume. So we feel this is salvageable. M1 occlusion is seen on the non-invasive study on the CTA. And here's our balloon guide. The imaging isn't fantastic because we do these awake. So the balloon guide is navigable. We said it's supple, it gets pretty high up. We're almost at the skull base. Here's the jet catheter. Here's the clot. You can see that stain right there in the clot. Basically corking it, getting it right up and engulfing it. Nothing so unique. we've inflated our balloon guide here. So we've created an anchor. We've arrested flow. Very straightforward, not that novel. And then as expected, or as one would hope, recanalization there. So that's our typical anterior circulation setup. I almost never change it. And then this is very similar in case you have a tandem setup. So this is a patient who comes in, again, the cornerstone of the stroke program, CT perfusion, increased time to peak, preserved volume, M1 occlusion, also missing is carotid. So this is a carotid occlusion. We tend to revascularize proximal to distal with the theory that flow begets flow. So if I can generate flow proximally, hopefully we get some autolysis or autolysis. So here we are stenting the carotid acutely. So the patient will be loaded with aspirin and Brilinta, most commonly. Small, an angioplasty, nominal, nothing crazy. You can see the balloon guide is in there. Now we see our occlusion distal. Here's our balloon guide here through the stent. We've actually now gone through the stent, so we have distal access. Here is our wire. Here's our microcatheter. Here is the aspiration catheter. The balloon is inflated now, gives me support to bring out the aspiration catheter. Here is a stent being deployed, hard to see, I know. So stent anchor, so stent, aspiration catheter, balloon catheter. Once everything's retrieved, the balloon is still inflated. There's our final Tiki 2B pre-op, post-op, nice result. So I know we, in the interest of time, I'd like to show some more. I want to switch. So that's kind of our anterior circulation setup. But posterior circulation, we don't use balloon guides. We don't have a balloon guide currently, so maybe someday in the future, but we don't really have a balloon guide that's going to be appropriate for the vertebral artery. So here, whether you use femoral or radial, you're not limited by your device size, and it may be advantageous to use radial, especially if you're dealing with a basilar occlusion and there's favorable vertebral artery access. So there's no restriction on the technique of the device. If you're in the femoral approach, whether you're you can use stent retriever alone, Solumbra, adapt, large bore aspiration. But it is challenging if you are going radial because you can't have that device size and you can't get that support. But posterior circulation is restricted. It's straightforward for the right vertebral artery, but we're restricted because of the size of the radial artery to basically 7 French. And every time, at least the literature and the coronary literature shows, when you go up to 8 French, there is an unacceptably high rate of losing the radial artery. Now, in most patients, that is not necessarily symptomatic, but in some patients who have a deficient ulnar, paucity of flow, already disease state, that can create significant morbidity in a patient. So be very careful when upsizing to 8 French in the radial. Definitely understand the radial anatomy, maybe inject through the sheath before you do it. So basilar occlusion, NIH 33, failed, didn't improve after TPA. So this is an example of a very favorable vertebral artery coming off the subclavian. Could you go from below? Absolutely, but no need. This is a small vertebral. We're not going to put a balloon guide there. We're not going to be, so whatever thrombectomy toolkit we're going to use the same whether we're radial or femoral. He got TPA. I sure don't want a retroperitoneal hematoma. Favorable site. This is a perfect case for transradial. So 6 French radial sheath. In this case, we used a 5 French Sophia. We could use a 6 French wrist, potentially a 7 French wrist, but maybe a 6 French wrist, given the fact that this is a small vert. Solitaire case, very straightforward. So proximal occlusion, 3 passes with the solitaire, the final result, very straightforward. So kind of what is the technique? And this is Jason's technique. We are looking at sheathless 8 French balloon guides, so sheathless walrus. So let's look at that real quickly. So lidocaine to the site, limit the lidocaine. When you make, so sometimes there's an exuberance of the lidocaine and you sort of can't feel the radial artery because there's such a big hump there. Some people use ultrasound. I have no issue with ultrasound. If you have a great pulse, you don't always need it. Sometimes you need it. So first thing we're going to do, if we're going to consider using an 8 French system, because I just told you there's an unacceptably high rate of radial artery occlusion on follow-up, and Andre and the team are going to be bringing all these patients back for follow-up Dopplers, so we can actually get a percentage of what is the occlusion rate. So the first thing we're going to do is understand, is there a loop? How big is that radial? Will it accommodate an 8 French? So this looks pretty decent. It's sort of borderline. So, but again, these arteries do stretch, but I would worry that this is a vessel that we would probably lose in this setting. So under the sheathless technique, once the sheath is in, it's sort of used as a dilator, we're going to use a stiff wire, put that all the way out in the aortic arch or potentially even the descending aorta so we can get a nice stiff rail, incise the skin a little bit so we can accommodate insertion of the 8 French guide, usually over your inner catheter of choice. So some type of inner catheter. In this case, probably use a Berenstein or something like that. And here's the walrus coming in sheathless. There's the balloon up top. Reconstituted. Maybe this was a sim select, it looks like. Here you see a carotid stenosis. And that is sort of the technique. And then we're going to inflate the balloon in the common. We're going to get support. So we started this talk also saying you don't get the same support when you're pushing heavy metal. By using a balloon guide, you sort of now negate that loss of support because you can use a balloon as a balloon anchor. So you inflate the balloon, it sort of elbows itself into the carotid, and now you have stability. So the initial experience using the sheathless technique that Jason's really championed here, 10 patients, show that it's feasible, show that it's safe. We're going to bring these patients back. Here's sort of just the list, size of the radial artery. You can see relatively, averages between 2 and 3 millimeters. This one's a little bit small, but we're going to see what is the occlusion rate on follow-up. So finally, going back to what we started with on the talk, mechanical thrombectomy using balloon guides in the radial versus the femoral. We're collecting that data now. So now we already said that it's really not the access site in stroke, it's your ability to use large bore devices and a balloon guide. That's what we should. That's why in the setting of stroke, I am 100% femoral in the setting of stroke for anterior circulation. Posterior circulation, dealer's choice, depending on the takeoff of the vert, as seen on CTA. I have no issue. But for anterior circulation, until I see other data, I'm 100% through a femoral approach, so I can use a balloon guide and large bore devices. So now we're looking at mechanical thrombectomy using balloon guides in the radial approach versus a femoral. So if we can use balloon guide, maybe the data is going to be similar. So for proper comparison, aspects greater than 6, MRS less than 2 pre-stroke, and then basically occlusions in the M1 and ICA. So basically these are the demographics. It's not that important, but you can see that basically similar across everything. So we have 63 patients in the transfemoral arm at the time, sheathless transradial 30 patients, so about half the number. There was a crossover. So for example, in 10% of the cases we tried to do transradial, crossed over to the femoral for complex anatomy. As we said, stroke is that black box. Sometimes you don't know what you're dealing with, and you get in there and you just can't navigate it. So there was a 10% crossover rate, which is also concerning in the setting of stroke, right? Because if you're every minute is 2 million neurons, so we're sitting there trying to get access, trying to do this through transradial approach, and now we have to cross over and restart femorally. We probably lost 10, 15, 20 minutes. Who knows how long we've been struggling, and that potentially is a significant amount of time when you're losing 2 million neurons a minute in the setting of a stroke. So what did we find though? So similar number of passes, first pass effect, mean or total is about the same, somewhere around TICI-2B. So that was interesting. And basically we had similar clinical outcomes. So symptomatic hemorrhages, 2 versus 1, so more. So this is more, but again, it's a small number in the transradial, but I don't think that has anything to do with the access. Hospital length of stay, about the same. Percent in hospital mortality, both around 15%, as you can see here, both around 15%. Functional independence, a little bit more in the transradial, but about 50, 60%. And then mortality rates, about the same. Nothing was statistically significant. Again, 30 patients in the radial arm, sheathless, 60 patients in the femoral arm. So the data, at least preliminarily, and again, this is underpowered, and potentially we can collaborate with the team at Swedish to add more data as we're collecting this data. We haven't published this yet, but we're looking to grow the numbers. Basically, using balloon guides radially versus femorally, it doesn't seem that the outcomes are superior based on access site, further demonstrating that outcomes are superior based on device choice. The crossover rate is still something of concern, though, at 10%. Example, again, anatomical variations remain the biggest challenge for radial access. And the take-home messages, specifically, I know we have about 10 minutes left for questions, are zealots, dogma have no place in neurosurgery. The choice of access should be based on which will give you the best armamentarium to effectively perform your thrombectomy on each occasion or whatever intervention you're doing. So the patient-first approach isn't always. I know I said there's no dogma, but maybe that's a dogma, patient-first. Take into account that quite a few vascular anatomic variables, we started with that, right? What's your target vessel? What's the size of the target vessel? What is the angle at which that target vessel comes off the arch? What is your arch anatomy? What is the arch physiology? Is it calcified? Is it shaggy? And that time is brain. So balance your choice with what will provide you the fastest and safest and most effective tools for recanalization. And I think with that, I know we have about 9-10 minutes left. We'll end and I'll open it up for questions. Thank you very much. And I'll stop sharing.
Thank you so much, Professor Levy. It was an amazing talk. Dr. Montidi is present here and he has a hand raised. So we're going to start with him.
Hi, Steve.
Hi, Elad. Thanks again for coming. And that was a fantastic talk. And I was so excited to listen to this talk because this is a topic of hot debate in our department for the last maybe 2 or 3 years. We have myself and Dr. McDougall, who are avid transfemoral first for stroke, but radial for other interventions, excuse me. And then our other colleagues, Dr. Patel, Dr. Lowe, and Dr. Timchak, I think, is in the middle, but Dr. Lowe and Dr. Patel are adamant about going radial. So we actually looked at the same sort of question that you looked at and came up with similar results. And I'd be interested to see your insight. When we went transradial and we had no problems, the results were the same as transfemoral, but where we did, just like your study did show, or is about to be published, we still had problems when we had to convert from radial to femoral in terms of time. And I think the next question, because we basically established the same issue, is predicting who we have to convert. Because if you don't convert, the numbers, the outcomes, the TICI scores, all that looks the same. So both parties are saying, well, you know, my way works just as good as yours or is better. But it's how do we predict who we have to convert to. Have you kind of gleaned any insight from that?
Great question. But also, right, anterior circulations, when we're using, I don't know if they're using balloon guides, but our outcomes were twice as good femorally because of the balloon guide, right? We used 8 French, and then you can get, and everybody knows those large bore catheters in the M1, right? You can't get a Zoom 88 or Zoom, those 71, the red 71 catheters through small guides in the wrist. So that was a problem. So I love those giant aspiration catheters in the M1 with a balloon guide. So our outcomes literally were 2x anterior circulation femoral versus radial. So I'm like you, femoral first all the way right now if you're in the anterior circulation. Conversion, yeah, when I'm looking at sort of a really floppy arch, type 3 arch, or sort of those tortuous acute angles on the left common, those are sort of no-goes. Those seem to convert almost all the time. We just struggle and then convert. And as you mentioned, right, those are the ones that don't do as well because you wasted precious minutes and now you're starting all over again.
Yeah, I think that's our experience too. But if we can figure out the details of that so we don't go there, I think that would be helpful, and we'd be happy to supply a large volume of patients for your study.
I would love that, and then I know your fellows are on, and Andre, maybe reach out with them and let's see if we can pull the data and make this more powerful.
Thanks.
Dr. Levy, one of the questions about your paper, the one of your retrospective series in the meta-analysis, I didn't see any description on crossover from femoral to radial to femoral. Do you know what your numbers are? I mean,
About, what'd you say, for 5? 9, about 10%. Yeah, so that's held true and consistent. It's about 10% crossover. And again, for the reasons you just heard us talking about before, typically it's the takeoff off the arches and just these sort of patulous, floppy type 3 arches.
Okay. What is your experience with left radial for left birth?
So left radial, I used to stand on the other side of the table and basically set it up like the right side, but then everything's backwards, right? So I'm used to using my right hand to insert, but now everything is backwards, and it was a challenge. So now if we take the left hand and put it over the patient's belly, and so now you're on the same side of the table and doing the same thing, you just have to basically have the patient put his hand over. The challenge is in Buffalo, sometimes we have very large patients and they can't put their hand over their belly. So it becomes a problem.
Do you have any experience? I mean, what is your thought about the jello balloon that has from 6 French to 9 French? I mean, I think the European are using that. Maybe in French you can use.
Cello it's a little bit older. I think it's not as navigable as either the Bobby or the Walrus. So we tried it early on, maybe a couple of years ago, and sort of got away from it. But definitely an option. Because you're right, it is 6 French, but I think the inner diameter is I don't know, but I think the inner lumen on that 6 French gets a little smaller.
Yeah. I know we discussed femoral versus radial, but what is your take on carotid sticks for strokes?
For strokes, not a fan. Very hard to hold pressure. So TCAR is very different, right? And I think TCAR has a role for when high-risk carotid by NASIC criteria and high-risk endovascular stenting. So terrible arch, terrible access. So you can argue there's a niche role for TCAR, but that's direct access, right? You can tie off the artery, but stick and then holding pressure, when you get a hematoma in the neck, can be very problematic. So again, what's old is new. And I know Nick and Cameron probably have a lot more experience than I do on carotid sticks, but people moved away from that for a reason. It's also very hard to work in this space. Your hands are all over their face, the angle of the jaw. So it's a challenge to work, and then it's a challenge to get hemostasis, especially if the patient had TPA in the setting of a stroke. It's just a lot of risk.
Okay. Do you have any advice on how to prevent radial artery thrombosis besides the catheter size? Yeah.
So a lot of that literature is Japanese literature early from the coronary, and they said duration of access and immediate removal. So if you can keep the procedure short on 8 French and then immediately remove it, they were able to salvage some of the radials. But that, again, once you get to 8 French, especially women tend to have sort of smaller wrists, smaller anatomy. That's a higher rate of radial artery occlusion.
Okay, you mentioned that the better recanalization and functional outcomes may be, I mean, related to the catheter size, to the aspiration. Did you compare MRS and TICI by catheter size?
Yeah. So I don't know. I can share the screen again. Can we share the screen? And I'll pull that chart. You go ahead and I'll pull that chart back up. Sorry, how do I go back up? Is it here? No. No, he's talking about the original study. Let's go here. So recan rates, that's a great question. So here's a femoral, 129 patients. Here's a radial, almost 100 patients, 93. So recanalization rate 80% versus 90%. And then out you asked for, and then mortality 40% mortality versus 20%, 34% outcome versus 51%.
Yeah.
So I think that if that answers your question.
Sure. Yeah. So in the video,
that's anterior circulation. So remember, and that's because 9 French guides, 8 French guides in the femoral were used 80% of the time. Less than 10% 6 French. Radial, 100% were 6 French. So we couldn't get those large bore aspiration catheters in the anterior circulation where you really need it. So I think that's what makes the difference, as well as a balloon guide. But when you look in the posterior circulation, identical results, because we're using pretty much 6 French for everything.
And do you know which part of the learning curve the surgeons were doing when they were doing the transradial for stroke? I mean, because
I think the guys have had, we as I said, we've been doing this for 2 decades, right? So we have a lot of experience in the radial approach.
Okay. Just one last question. In the video with the balloon mounted thrombectomy, we saw that you usually use you went with the balloon pretty distal.
Yeah.
You try to go as distal as possible with the balloon?
Yeah, I probably won't go across the petrous carotid, but I'll definitely bring it up as you can see here.
Yeah, right.
I'll bring it right up to the skull base, whatever the anatomy lets me. Certainly, it's pushability, it's flow arrest. I'll let the anatomy dictate how far I get it up, but usually I won't go past the skull base, but I'll go very distal in the ICA with a walrus or a bobby, but not with sort of the older generation devices.
Nice. Yeah. So there is a question here from the audience, from Esteban Ramirez. He asks you if you always do some kind of arch study before your procedures, like CTA.
So we have the the Aquilian, I'm sure, and every company has that. So when we get a CTA, in the CTA, it's head and neck. So it gives us the top of the arch all the way up. So we see the arch in that point, and we can see the vessel take off. We can stop sharing. We talked about it being the black box and sort of an unknown, but you do get a glimpse. You do get a glimpse of the aorta, and so you can make some sort of quick decisions.
Okay. One of the fellows, Leo, I think you had a question.
Sure. Yeah. Thanks for your talk, Dr. Elad Levy. It was great. Sorry I missed some of it with dealing with an emergency in the ICU. So my question is, just as a segue to the statement about the CTA of the chest, and looking at the arch and CTA of the head and neck as well. So when you're planning the procedure and you look at the anatomy, do you ever think that you may have to start with radial, and then you already have the groin prepped, and then just in case you have to start with radial, not for stroke, but for other procedures when you look at your anatomy, and even if you're going into the left internal carotid, you think the anatomy is more favorable. Some people argue, for instance, the bovine arch is actually more favorable for radial. So if you see a bovine arch, which has often been something we mentioned as a negative for femoral, but it seems to have the opposite effect on radial.
Yeah, you're 100% right. So if it's bovine and it sort of has a sim2 curve, right? So you come out of the subclavian and it almost naturally wants a curve into the left common. That is a great choice, and we can navigate that. And especially now with 7 French wrist, we've done a lot of intervention with 7 French wrist, or even sometimes balloon guide railed over a VTEC and an 038 wire. Yeah, no dogma. So bovine is can be challenging from the femoral, and if it's more favorable from the radial, we'll certainly do that electively, but not necessarily in the stroke setting.
Okay. One last question, maybe for Andre. In the meta-analysis from Buffalo that you did on radial femoral for stroke, what was the crossover of the groups? Not your specific one.
I recall was 8.5%.
Okay, so pretty similar, around 10. Okay, thank you so much, Dr. Levy. It was a pleasure to have you and very useful for us.
Thank you for inviting me and for hosting. Thank you guys very much.
Thank you so
Thank
much.
you. That was great. Pretty helpful.
Have a nice day.
Thank you, Dr. Levy.
Thank you so much.
See you, everybody. Thank you.